Whereas in case of retinitis, we'll get this whitish fluffy mass which will have severe vitritis most of the times, and we won't be able to see the retinal vessels. Also, OCT, sometimes it is very important to diagnose the case of retinitis if we are confusing it with choroiditis. So on OCT, if we take a scan through that lesion, we can see the presence of thickened retina and along with increased hyperreflectivity, whereas the choroid will appear completely normal. So now I'm going to discuss some of the important viral retinitis causes. So one of it is CMV retinitis. So CMV retinitis is the most common opportunistic infection in AIDS or immunocompromised patients. It's usually seen when CD4 count goes below 50 cells per microliter. And in patients with HIV or patients with organ transplant, those patients who are on steroids, they usually will have such kind of presentation. So there are 3 types of clinical presentations. The first is fulminant type, wherein we'll have this wedge-shaped area, also called as pizza pie appearance, wherein we'll have this fluffy white lesion with multiple scattered hemorrhages, also known as brush fire appearance. The second is a granular variety, wherein there will be such granular appearing retinitis lesion. There will be very few hemorrhages. And the third is frosted branchiangitis, wherein the retinitis would be along the vessels or along with perivascular sheathing. So in a pre-heart era, the incidence of CMV retinitis was 25 to 42%, but after heart therapy, the incidence decreased by 75%. It also led to slower progression of the retinitis, and it reduced the HIV viral replication. Coming to the treatment, the drug of choice is ganciclovir in CMV retinitis, which is a virostatic drug. It inhibits the viral DNA polymerase. It can be given in the form of sustained release intravitreal implant or as an oral drug or intravenously. So intravitreal implant of ganciclovir, which is also called as Vitrasert, it's available in the 4.5 milligram capsule. It releases the drug with the rate of 1 microgram per hour for 6 to 9 months. But we know that CMV infection is a systemic infection, and therefore a systemic therapy is must. So therefore, an oral valganciclovir, which is a prodrug of ganciclovir, is given at the dose of 900 milligram 2 times a day for 2 to 3 weeks, followed by 450 milligram once a day. But the side effect associated with this is myelosuppression. Therefore, a CBC count should be monitored. And there are multiple reports which have shown that the oral valganciclovir is equally efficacious as that of the intravenous ganciclovir, and therefore can be used as a monotherapy. Now, there is an entity called as immune recovery syndrome, which is associated with HIV patients after starting heart therapy, after which after the patient's immune system develops, there will be inflammation like anterior segment inflammation, posterior synechiae, cataract, vitritis. There can be macular edema and also epiretinal membrane. So in such case, we'll start topical therapy of steroids. Now, the second viral infection is acute retinal necrosis. Now, it's a very uncommon entity and it's usually seen in immunocompetent individual. However, it can also be seen in patients who have immunocompromised conditions. So it basically presents with a peripheral retinitis. There will be multifocal peripheral retinitis patches along with occlusive vasculitis. There will be inflammation in AC as well as in vitreous. And there will be characteristic perivenular sparring. So it will give appearance of a cracked mud appearance. So the viruses responsible for it are varicella zoster, herpes simplex, and simplex 1 and 2 virus, and in some reports of CMV and EBV viruses have also been found out. So there will be a classic triad of panuveitis with occlusive retinal arthritis with peripheral retinal necrosis. The incidence of retinal detachment in ARN is around 50 to 73%. Now coming to the treatment, the standard treatment is giving intravenous acyclovir for 5 to 10 days. The dose is 10 mg per kg every 8 hours. And then adding oral acyclovir of 400 to 800 mg 5 times a day for around 6 to 12 weeks. We can also add intravitreal ganciclovir, especially if there is a severe vitritis or the optic disc is getting involved. In such case, we can also add intravitreal ganciclovir. Dose is 2 to 4 mg per 0.05 to 0.1 ml. Now the current trend is to start oral therapy alone. So there is a prodrug of acyclovir, that is valacyclovir, or we can also give a famciclovir. It has a better bioavailability than that of the oral acyclovir. So oral acyclovir is given at the dose of 1000 milligram 3 times a day for 12 weeks and then slowly tapered. So it's very easy to administer. The patient is more compliant. The patient doesn't have to go to hospital for intravenous administration of acyclovir. So therefore, it can be preferred as a first line treatment in ARN. And basically, steroid doesn't play a mainstay of treatment in such cases. It's the antiviral therapy only. We may add steroid after 2 to 3 days of starting antiviral if there is severe vitritis or optic nerve involvement. Now the third infection is progressive outer retinal necrosis. So it's a variant of ARN. It is seen in patients who are immunocompromised like HIV, and the viruses responsible for it can be varicella zoster, herpes simplex, or CMV virus. As opposed to ARN, there will be minimal vitritis and there will be multifocal retinal opacifications which will be more confluent. And they have very early posterior pole involvement. Therefore, its treatment need to be started as early as possible. The treatment is intravenous ganciclovir with the dose of 5 mg per kg, 12 hourly for 2 weeks, followed by 5 mg per kg. We may also add intravitreal acyclovir if there is a posterior pole involvement. But it has a very poor prognosis. These are some other viral retinitis like subacute sclerosing panencephalitis, which is basically seen after measles virus infection. Its ocular involvement is seen in 50%. It may present with macular retinitis, chorioretinitis, papillitis, or optic atrophy. Now, recently, COVID-19 has also been found to be responsible for CRVO, CRAO, retinal vasculitis, and choroiditis. Dengue fever, it usually presents with retinitis and foveolitis. Chikungunya can present with iridocyclitis and retinitis. Now, what about investigations? So it's basically the clinical diagnosis, but sometimes ocular investigation can help us in conditions wherever we find it to be confusing with choroiditis. So OCT, again, as we had discussed, will help us to diagnose whether it's a retinitis or a choroiditis. Fundus fluorescent angiography will help us to know whether there is a presence of neovascularization. Now, systemic investigation of like serology titers can be done to look for the viral etiology. Sometimes we can also do a PCR of AC tab or a vitreous tab or a biopsy to confirm the diagnosis. But the diagnosis is primarily clinical. So to conclude, we suspect a viral etiology, especially when we have a large retinitis patch which are spread along the blood vessels associated with diffusely distributed KPs and high IOP. And we must start antiviral as early as possible. And recently, the trend is to start oral therapy alone. This will help to save the life as well as the eye. Thank you.
Thank you, Dr. Anuja. So, Dr. Anuja, can you tell other causes of retinitis besides viral disease which we need to keep in mind while treating a patient?
Yes, ma'am. Retinitis can be inflammatory or infective in etiology. If we talk just about infective, then it can be bacterial also and fungal also. So, as I told that the viral etiology has a classical presentation that it spreads along the blood vessels. So that is very characteristic of viral retinitis. So that we have to keep in mind. The bacterial and the fungal, it usually involves the posterior pole, but the viral, they usually tend to present in the equator area or in the peripheral area.
Okay. So besides that, we have investigations also supported.
Yes. Yes.
Thank you so much.
Thank you, ma'am.
So that was really a wonderful presentation. And now we have Dr. Yuganki. She is going to present COVID associations in the eye.
Good morning, everyone. And I hope after living 2 years in COVID, we are all very well aware about the COVID manifestations of the eye. I would just like to touch on the topic. So the prevalence of the ocular manifestations in patients of COVID-19 ranges from 2% to 32%. The variation in the prevalence is because the exact prevalence cannot be commented upon because of the varied presentation at different time intervals and in different phases of the disease. So this is just a broad timeline of the different ophthalmic manifestations, which can be divided into the ocular symptoms presenting initially, that is before COVID-19 or within the first week of onset, that is the acute onset, 0 to 7 days. Symptoms presenting between the second to third week are classified as subacute, and those which present as a late sequelae of the infection are called as delayed symptoms. So this is just a broad timeline telling us that conjunctivitis, keratoconjunctivitis, and episcleritis, they can present as acute or subacute, whereas the retinal manifestations and the neuroretinal things can present in the acute form and continue to present as a delayed presentation, whereas when we see conditions like central retinal artery occlusion, they usually present in the second to third week and continue as a late sequelae. So the COVID manifestation in the eye can be classified, can affect all the structures from the eyelid till the optic nerve. So if we talk about the ocular surface and the cornea, so this is just the basic signs and symptoms. Dryness, pain, discharge, redness, which are very common symptoms of MGD, are seen up to 24.1% of the patient. The patient can also present with foreign body sensation, photophobia, itchiness, which is usually seen in cases of conjunctivitis. And lid margin hyperemia, crusted eyelashes, meibomian orifices abnormality are also seen. Coming on to the conjunctivitis, which is one of the most common ophthalmic manifestation documented in COVID-19 patients. There are various case reports presenting different forms, the most common one being the follicular one and the hemorrhagic pseudomembrane. Also, there are a few case reports mentioning that because of the corneal involvement, it was a keratoconjunctivitis. I would like to mention that there are few case reports saying that there were conjunctivitis in children, which was classified as multi-system inflammatory syndrome in children, and it is a condition resembling Kawasaki disease. So this is just a table showing that various presentations were reported by various authors from worldwide as conjunctivitis as the first symptom. Then coming on to the second presentation can be in the form of episcleritis and scleritis. There are 3 case reports. Otef et al. Reported that 29-year-old male with unilateral episcleritis as an initial presenting symptom of COVID-19. Then there was another one in which a 31-year-old presented with a nodular episcleritis. And there were 2 case reports by Fez et al. Saying reporting anterior scleritis in patients with COVID-19. It was a delayed sequelae. Coming on to the posterior segment manifestations, my colleague has already stressed upon very nicely the various viral manifestations. I would just like to classify them. So there have been very few case reports which say that there were conditions like serpiginous choroiditis. Then majorly the COVID-19 symptoms were of the retinal vascular occlusion because of the coagulant state that is produced, and there were a lot of cardiovascular diseases also. So it majorly affects the arteries and the veins in the form of central retinal vein occlusion, central retinal artery occlusion, acute macular neuroretinitis, and paracentral acute macular middle maculopathy. Other retinal manifestations which have been reported in literature were in the form of acute retinal necrosis and vitritis and abnormalities of the outer retinal layers. Neuro-ophthalmic manifestations, there are very few case reports because these were in the patients who were hospitalized and with very severe COVID infections, but there are cases mentioning papillophlebitis, optic neuritis, AD stonic pupil, Miller-Fisher syndrome with cranial nerve palsies, 3rd as well as 6th, neurogenic ptosis, and CVA with vision loss. And to just touch upon the orbital manifestations of COVID-19, mucormycosis, as we are all aware, has been disaster in the COVID-19 era. Besides this, there have been reports of patient presenting with orbital cellulitis and acroadenitis, and few with a retroorbital vein. Thank you.
So thank you so much, Yuganki. Now we have Therapeutics in Viral Disease by Dr. Garvita.
Good morning, all. Sorry. Good morning, all. I'm presenting the therapeutics of viral disease, the old and new. Beginning from the history of the viral keratitis, the viral therapeutics, in the year 1959, Dr. William Prusov developed idoxuridine as a potential anti-cancer agent. The mechanism of action involved blocking of the DNA synthesis. It was too toxic as a systemic agent. However, it proved to be a good topical treatment against the DNA virus, which is the herpes simplex virus. Hence, in the year 1962, it was marketed to be the first treatment of choice for herpes simplex keratitis. However, it was associated with toxicity, superficial punctate keratopathy, chemical conjunctivitis, punctal occlusion, occasional serious hypersensitivity reactions. It was unable to penetrate the corneal epithelium or to treat the stromal and endothelial keratitis. Therefore, gradually over a period of time, multiple drugs, especially acyclovir, was developed in the year 1982. The multiple regimens available are topical and oral antivirals, which I will explain. First topical antiviral was acyclovir, available as 3% ointment given 5 times a day for 7 days, then 3 times a day for the next 7 days. Specific for viral infected cells only. However, it was not available in US, and the resistance may be increasing by 10% in immunocompromised patients as per the literature. Systemic acyclovir in the dose of 400 microgram orally 5 times a day for 7 to 10 days. It is as effective as topical acyclovir and toxicity is rare, but it includes normal systemic functions like kidney and liver functions. Topical ganciclovir available as 0.15% given 5 times daily till the ulcer is healed, then 3 times a day for the next 7 days. It's increasing usage in US and Europe, but not in India. Topical trifluridine available as 1% solution 4 to 8 times a day. It's the first line therapy in US, as effective as topical acyclovir. Topical idoxuridine, it was the first topical antiviral, but not the first choice at present. Oral antiviral require a good renal function and always go for a baseline LFT test before the therapy started, especially with acyclovir. ARA-A gel is a topical 3% ointment. It has been withdrawn from the US and UK market, but available in developing countries. Herpes simplex stromal keratitis requires topical acyclovir, systemic acyclovir, and topical trifluridine. This is always in addition with topical corticosteroids. Acyclovir 3% ointment, similarly. Systemic acyclovir 400 milligram orally 5 times a day for 10 weeks, and topical trifluridine 1% 4 to 8 times a day for the 3 weeks. Prophylaxis treatment after the HEDS2 trial, systemic acyclovir was proven to be useful for prophylaxis. Acyclovir 400 milligram orally twice a day. Antiviral treatments for herpes zoster are extensive. Systemic acyclovir given 800 milligrams 5 times a day for 7 days. In detail, if we go about it, the non-ocular involvement at onset treatment must be started at 72 hours after the onset in order to limit the infection. Topical acyclovir is 3% ointment 5 times a day for 7 days, and then twice a day till the dendrites are resolved. Topical ganciclovir 0.15% till the ulcer is healed, then reduce. Systemic valcyclovir is 1 gram orally TDS for 7 days. Systemic famciclovir 500 orally 3 times a day for 7 days. It is potentially better than acyclovir in reducing acute pain of the herpes zoster. Adenoviral infection, there's no licensed antiviral against the adenoviral infection. As per few literature reports, there was a RCT trial of povidone iodine 0.6% with dexamethasone, but of course this was only a 12-day study, and it's not commercially available, so this is not exactly encouraged, and studies are required. Viral metaherpetic keratitis requires surface support more than antivirals. There we need first elimination of toxic medications followed by punctal occlusion, tear supplements, bandage contact lenses, autologous serum tears, amniotic membrane grafts, cautious use of topical steroids. Posterior segment viral infections treatment has been extensively discussed with my colleague Dr. Anuja. So the key points that should be taken care of when we start the therapy in viral keratitis are, firstly, valcyclovir, ganciclovir became available after the HEADS-2 trial. They are more efficacious and less toxic, though they are encouraged. Second, topical antivirals currently available and oral antivirals. The most effective at present are acyclovir, vanciclovir, and famciclovir. Prophylaxis with oral antivirals is suggestive in patients with HSV keratitis, especially if they go for a refractive surgery or a cataract surgery. Also, the use of steroids in viral keratitis, it has both pros and cons. The advantages are inhibition of cellular response, limitation of opacification, scarring, inhibition of neovascularization, but it has cons like it can stimulate viral replication, it can cause corneal thinning, steroid induced glaucoma, or even cataracts. HSV can lead to latency and recurrent disease in the nerve endings. There is at present no treatment for latent infection. Only when it goes into active states, only then we can treat the patient. There is an ongoing research of subcutaneous administration of heat-activated HSV against the antigens. However, it's very limited, and not much more studies are required in this area. So that's it. Thank you.
So thank you so much, Garvita. That was really wonderful presentation. And with this, we end our instruction course. Thank you.